Bismillahirrahmanirrahim, ladies and gentlemen, Assalamu alaikum and a very good morning all of you. I'm your host Dr. Sadia Aslam, resident internal medicine, Jinnah Postgraduate Medical Center, Karachi.
And I am Mohammad Saad Pasha from Liaqat National Hospital and Medical College.
With immense pleasure, we would like to welcome you all on the first day of 26th Annual Conference of the Pakistan Society for Rheumatology 2023. Today we have the great privilege of having with us some of the brightest minds in the Society of Rheumatology. We are very thankful and highly obliged to all of you for joining us today.
Ladies and gentlemen, at this year's conference, as we come together from different institutions from across the globe, we have at hand a tapestry of different ideas, experiences, and perspectives, which will hopefully add up to an exciting day ahead. Ladies and gentlemen, let's have a brief overview of what is to come. We have a packed agenda ahead of us, filled with engaging and insightful discussions and opportunities for collaboration and networking. But before we dive into the exciting sessions planned for today, let's take a moment to appreciate the hard work and dedication that has gone into making this conference possible. Ladies and gentlemen, can we please have a round of applause for the organizing committee?
Ladies and gentlemen, without further ado, we would like to introduce the chair of the first session of today's conference, Professor Emeritus Khalid Mahmood. Professor Khalid Mahmood, Dean and he is a meritorious professor of medicine, Dow University of Health Sciences, Karachi. For his excellent performances and outstanding performances, he has been awarded the prestigious Idara-e-Imtiaz. Dr. Khalid Mahmood, we would like you to please join us on stage.
Ladies and gentlemen, Professor Emeritus Khalid Mahmood, please allow us to introduce the co-chair for the first session of the day. Professor Dr. Kamran Hamid has served as the chair at the Department of Medicine, Aga Khan Hospital, Dar es Salaam. He has also previously served as the Dean of Medicine at Ziauddin University. Professor Kamran Hamid has a keen research interest in clinical rheumatology and rheumatoid arthritis. Ladies and gentlemen, Professor Kamran Hamid.
So starting with the first session, we would like to introduce our first speaker of the day, Dr. Suleman Khan. Dr. Suleman Khan is currently serving as a consultant rheumatologist at Afridi Medical Complex, Peshawar and Kulsum International Hospital, Islamabad.
He helped establish the first ever department of rheumatology in the Khyber Pakhtunkhwa province, a province with a population of 35 million, which was previously devoid of any rheumatological facilities. But thankfully, that isn't the case anymore, thanks to Dr. Suleman Khan's contributions. We're very grateful to Dr. Suleman for joining us today. The topic of his discussion today will be antiphospholipid syndrome. Ladies and gentlemen, Dr. Suleman Khan.
Bismillahirrahmanirrahim. Assalamu alaikum. It's a great pleasure to be here today in Karachi. Last time when I was here, I really enjoyed all the sessions and the conference, and great to be here once again today. So the topic that I have been given today is unusual presentation of antiphospholipid syndrome. Right, so what is antiphospholipid syndrome? It is a prothrombotic condition, as you all know, and it can affect the arteries, the veins, it can have obstetric complications in the presence of different autoantibodies. It can occur as a primary condition, it can occur as part of other autoimmune conditions, so based on that primary or secondary subtypes. When we look at the pathophysiology of the condition, there is a combination of different things and events that happen between proteins, between cells, between cytokines, platelets, and that actually leads to thrombus formation in different blood vessels. I probably will not go into details of all the different autoantibodies and its reactions with different cells and cytokines, but that's what we get normally as a part of the condition. When we say unusual, it's a house upside down. It's not classical picture that you normally get, and diseases can present in so many different ways. And it is important to recognize that this particular condition, which is primarily difficult to diagnose in some cases, even if you apply the criteria that we use for antiphospholipid syndrome, when things come in unusual way, things are even more challenging then. So the first presentation can be in so many different ways, but classically it's a thrombus formation which can affect the veins, the arteries, and likewise you get capillaries involvement, and so on and so forth, particularly the pregnancy-related complications with recurrent miscarriages and premature births. But at the same time, we get non-thrombotic problems in this particular condition also, such as valvular heart disease and neurocognitive disorders, including even dementia. But it is interesting, when we talk about antiphospholipid syndrome, we historically have been using the criteria to sort of use autoantibodies and check them at 12 weeks interval. But thankfully, now it is a little bit easier as the ACR and EULAR have got this 2023 criteria, which is very good, and I personally like it so much. The first 6 domains actually involve venous aspect of things, then arterial, then microcapillary or microvascular, then obstetric, and then we have got cardiac, where you can have cardiac valvular thickening or vegetations, and finally thrombocytopenia. So remember, platelets are important now, and as part of the consumption coagulopathies, you can have low platelets, so thrombocytopenia you need to watch for. And then after that, the domain 7 is about lupus anticoagulant. If your lupus anticoagulant is positive just once, it gives it gets a score of 1, but if it is persistently raised, a score of 5. And then you have got the other autoantibodies, anti-beta-2 glycoprotein 1 antibody, and then you have got anticardiolipin antibodies. And then it depends on the titers, and then whether one of those 2 antibodies are present or both are present, then you get particular scores for that in that manner. So if a patient gets a score of 3 out of the first 6 domains and a score of 3 out of the last 2 domains, then you can regard them as antiphospholipid syndrome. But the story is interesting because probably the 12 weeks interval testing of autoantibodies is still important, because at times we come across transient antiphospholipid antibodies in the body system, and that is not always due to antiphospholipid syndrome itself. So I probably will skip reading all this text, but this is, I'm sure you're all aware of. This thing is interesting. Now, when we talk about criteria, when we talk about classical presentation of conditions, the artificial intelligence is coming into play quite a lot these days. So I'm thinking that maybe in future, not many physicians probably will be required. And beyond that, there might be a time where patients will use an app on their Android or iPhone to put all the symptoms or their tests, and they probably will get their diagnosis there and then. And maybe at some point they probably will be managing their own condition with treatments and different things. So this is really important. But when we consider ourselves as rheumatologists and physicians, we do still probably have quite significant role when it comes to dealing with unusual presentations of conditions, and antiphospholipid syndrome, of course, is not an exclusion. So this is something that we need to be aware of, that it will be coming into play quite a lot in the coming years to come. But are diagnostic criteria all that important? Perhaps yes. And yes, because you want to ensure that there is consistency in identifying and categorizing medical conditions. The diagnostic criteria guide us in terms of treatment decisions and research, etc. But if you answer no, probably you're not incorrect. And that is because that some people argue that rigid criteria may lead to misdiagnosis in unusual cases. And clinical judgment and individualized assessment are still very crucial, and that's what our role as rheumatologists and physicians is. So just to give you a brief overview of a few cases, so this particular paper highlighted about different aspects of unusual presentation of antiphospholipid syndrome, and one of the catastrophic condition is the catastrophic APS, which happens in 1% of the population. And I'll probably discuss a few things about catastrophic APS in later slides. There is this concept of seronegative APS, which probably is not so valid now, considering all the criteria and the autoantibodies profiles. So you can have nervous system involvement, including TIAs, strokes, you can have epilepsy, dementia, chorea, transverse myelitis, ischemic or inflammatory sort of responses, but at the same time, visual impairment with transient ischemia, retinal artery or venous occlusion or optic neuropathy can happen as well. And likewise, cardiac vegetations, valvular thickening, valvular impairments, you can have pulmonary hemorrhages, and so on and so forth. So the condition itself can affect various organ systems in so many different ways. Skin, kidney, and pregnancy-related problems you're all aware of. You can have livedo reticularis, you can have retinal artery occlusion and shrinkage of the kidneys and reduced size and later on impairment as well. And then you can have all the miscarriages and fetal death and premature delivery, intrauterine growth restriction, and hypertensive disorders in pregnancy. Another paper, this highlighted that, again, similar things with nervous sort of neurology involvement, renal involvement, and then skin involvement. You can have avascular necrosis of the bones as well, and pulmonary hemorrhages, etc., and cardiac valvular involvement. I probably will not spend much time on management of APS. You all know that if it is a confirmed antiphospholipid syndrome and if there is no contraindication to warfarin, that will be your classical drug to use. But in pregnancy, you will be looking at low-dose heparin and low-dose aspirin and heparin in that combination. A couple of years back, I presented a case of a young lady who had several miscarriages, and then with the use of heparin, hydroxychloroquine, and low-dose prednisolone, actually I used 5 or 10 milligrams, and she conceived, and she has a lovely daughter now. Immunomodulatory treatments, definitely if it is part of secondary antiphospholipid syndrome, you'll be using those as well. And there's a lot of research opportunities. The problem with antiphospholipid syndrome is that, you know, the incidence and prevalence is not so much, and perhaps a multi-center study can help us getting more numbers. This paper actually looked at a 25-year-old gentleman who had dizziness, syncope, seizures, headache, blurred vision, and some infections, and he was found to be hypertensive as well, with renal impairment, proteinuria, mitral valve thickening, mitral regurg, retinal arteriole constriction, and cerebral microvascular ischemia. He was found to have positive lupus anticoagulant, cardiolipin, and anti-beta-2 glycoprotein antibodies. And there are some pictures of his histopathology. So basically, the condition can affect any organ system, any organ for that matter, because wherever blood supply is and blood vessels are, you can have an adverse impact on that system. So dealing with unusual cases of antiphospholipid syndrome, misdiagnosis happen, and one of the things that we need to learn as physicians, that we need to realize the fact that at times we may misdiagnose, and we need to always look back and take the history from the scratch, do the examination from the scratch, look at everything from the scratch, and rethink about our diagnosis. We come across not only this sort of situation in conditions like APS, but other inflammatory arthropathies as well, where you are thinking that the patient has inflammatory arthropathy, and you're treating them and loading them with a lot of DMARDs and steroids, but they are not responding. So you need to think about alternative diagnosis. So that happens, and if that happens, the outcome can be catastrophic. The outcome can be associated with significant morbidity and mortality. And that's why we always need to look at differential of antiphospholipid syndrome. So some of these conditions can be with the thrombotic events can happen as part of inherited thrombophilia, acquired thrombophilia, vascular obstructions due to several reasons, and then chromosomal abnormalities, uterine abnormalities, and endocrine disorders. But this is important. If a patient has got antiphospholipid positive antibodies, any one of those antibodies, it could be transient antiphospholipid positive antibody. It could be as part of the SLE, where the patient does not have any history of thrombotic events or any pregnancy-related problems. It could happen in infections. Interesting. It can happen in due to medications. You remember that hydralazine and things like that can cause drug-induced lupus as well. So some medications can react in a funny way, and the immune system is quite funny as well. So you can get these positive autoantibodies with drugs as well, and in malignancy. So if we miss antiphospholipid syndrome, what happens? So one of the catastrophic events is the catastrophic APS, which happens in 1% of patients, and the criteria is given on the right of the slide. I'm not going to read that all, and I'm sure you all know this, but this is something we need to avoid, because the prognosis for this particular condition can be guarded, and the patient can become really, really unwell. And the rest is all the same pregnancy-related problems, thrombotic events, strokes. So, just narrating this and describing these complications is easy, but it has enormous effect on patient outcome and personal health of the patient. For example, if a young guy gets stroke, then, there can be potential impairment for the rest of their life. Renal involvement, skin problems, and neuropsychiatric sort of syndromes. So how do we actually avoid this? Well, it's simple. None of us should be an all-rounder, really. I think we need to sort of look at the bigger picture, look at the outcome of our patients, and not just purely rely on our own knowledge and skills to say that, well, I am the master, I'll treat with this and I'll deal with this, I don't need any help. That's wrong. So that's totally wrong. You need to have, a multidisciplinary approach, but basically, you need to give time to patient as well. So in a busy clinic where you are seeing 100 patients in one evening, how are you going to go and focus on some very important aspects of history, of examination, and of course there is a lot of difficulty in getting these immunology tests here in Pakistan, of course, because of affordability issues and all that. So specialist consultation, work with colleagues, involve hematologist, immunologist, anyone for that matter. If you're not sure about the libido changes or skin changes, ask your colleagues in dermatology, ask your nephrology colleagues if there is any trouble in terms of renal involvement, for that matter. So basically, collaboration and specialist consultation, not only from clinicians' point of view, but you can involve other allied health professionals as well. and the idea should be a better patient outcome rather than you keep on the same patient for years and years and then end up in complications, not sort of asking your colleagues in a timely manner. So that is the emphasis on interdisciplinary holistic care, expertise, and MDT sort of approach for better patients' outcomes. I'm really grateful to you all. Thank you very much indeed.
Thank you, Dr. Suleman Khan. We are very grateful to Dr. Suleman for his contributions to the Pakistan Society for Rheumatology in his capacity as the General Secretary. It has always been a pleasure having Dr. Suleman Khan with us.